So she'll be talking on functional outcome in patients undergoing orbitotomy for orbital cavernous venous malformation.
Good morning, all. I'm here to present my paper on functional outcome in patients undergoing orbitotomy for orbital cavernous venous malformation, a retrospective study. No financial interest. As we know, orbital cavernous venous malformation is a simple venous malformation seen in females around 30 to 50 years of age. The clinical course is varying, can be asymptomatic to symptomatic. Excisional biopsy remains the treatment of choice. However, there is a wide discrepancy between the treatment as visual impairment can occur due to surgery in around 2 to 24% of cases. So in this context, we did a study to analyze the functional outcome in patients undergoing orbitotomy for intracorneal cavernous venous malformation. It was a retrospective interventional study from 2014 to 2022 in a tertiary care center in South India. Detailed history, complete ophthalmic evaluation, orbital imaging was done in all the cases. Tumor volume was calculated considering cavernous hemangioma as an ellipsoid using the formula 4 by 3 into pi into h by l. Small tumors less than 3 ml were considered as small tumors and more than 3 ml were considered as large tumors. The surgical approach determined based on the location. Lateral orbitotomy without osteotomy was done. Lid split approach was also done. Cryo-assisted tumor removal was done in all the cases. Muscle disinsertion and reinsertion in some of the cases. Pupil was monitored throughout the surgery. All patients with a 6 months follow-up were included in the study, and those referred for revision surgery as well as in extracorneal location were excluded. Patient was admitted for 1 day, followed by discharge, and followed up on 1 week, 1 month, 6 months, and yearly thereafter. Refraction was done at 1 month. Histopathological confirmation was done in all the cases. The functional outcome was determined in terms of changes in visual acuity and refractive error, ophthalmoscopic changes, and complications related to surgery. So we had 10 eyes on 10 patients with an average age group of 44.4 years. Females outnumbered males in the study. Follow-up ranged from 6 to 60 months, the range of 21.8 months. So the main presenting symptom was protrusion followed by defective vision in our series. Color vision was normal in all the patients pre and post-operatively. Visual fields was also normal. One patient had central scotoma. Coming to the ophthalmoscopic findings, 4 patients had chororetinal folds. It remained in the postoperative period also. 1 patient had serous macular detachment, which also remained in the postoperative period. The disc edema, 2 patients had and 2 got resolved. Coming to the changes in visual acuity, 1 patient had less than or equal to 6 by 18 vision, whereas all the other patients had more than 6 by 12 in the preoperative period. In the postoperative period, all patients had more than or equal to 6 by 12, out of which only 1 patient had 6 by 12. That patient had a serous macular detachment. Coming to changes in hypermetropia, we had 7 cases with hypermetropia ranging from plus 0.5 diopters to 5 diopters, of which 4 eyes had more than or equal to 2 diopters and the rest had less than 2 diopters. In the postoperative period, out of the 7 cases, 5 patients had residual hypermetropia, of which 1 patient had more than 2 diopters. 2 patients became emmetropic. 1 had plus 1.5 diopter and plus 0.75 diopters. Considering the average hypermetropia preoperative and postoperative, there was a reduction of 33.6% reduction in average hypermetropia. Coming to the radiological features, CT scan was done in all the cases. The maximum horizontal dimension ranged from 1.4 millimeter to 2.9 millimeters. Tumor volume was calculated in 8 cases, ranging from 2.1 to 7.6 ml. Optic nerve displacement was present in 2 cases. Inferolateral was the most common location. Coming to a surgical approach, 7 patients underwent lateral orbitotomy alone, 1 patient underwent lid split approach alone, and 2 patients had combined approach. In one case, we did disinserted the middle rectus and then deinserted. Complications, 1 patient had tonic tonic pupil, remained at the last follow-up, and 1 patient had late enophthalmos. So this is a sample case, 45 years, female, came for non-case of hypothyroid, presented with protrusion. This is her preoperative refraction. Ocular movements were full. Fundus disc edema. And CT scan showed intracorneal mass in the superior quadrant. She underwent lid clease approach. Follow-up at 1 month. So coming to discussion, it's a unique study of 10 patients where we have used a combined approach in orbital cavernous hemangioma and no loss of vision in any of the case. And this is the first study reported from India. Coming to the visual impairment following excision for cavernous hemangiomas, from the previous series, there was an incidence of around 1.2 to 4.5% of no light perception following surgery. Posterior optic nerve ischemia, central retinal artery occlusion, caused by traction and manipulation of orbital tissues is the cause. posterior located tumor, optic nerve proximity, large and long-standing tumors are the most important risk factors. So in our series, we have done a dual approach, that is combining two approach, and muscle was disinserted when there is a possibility for loss of vision, as well as all the patients had a good preoperative visual acuity. Coming to the changes, we had an incidence of 70% hypermetropia and only 33.6% reduction in hypermetropia noted. This is correlated with the other studies where in 75% of cases the hypermetropia was retained in spite of complete removal of the tumor. So scleral fibrosis and remodeling with a chronic distortion can lead to permanent scleral deformation, and permanent change in axial length could be the reason. Tonic pupil was seen in one patient, but she was asymptomatic. Yan et al. Reported at 6.5% incidence. It can occur due to the injury to the short ciliary nerve or ciliary ganglia. So, what this study adds, functional outcome following orbitotomy for orbital cavernous malformation remains excellent with a careful surgical technique. Proper selection of surgical procedure and careful intraoperative dissection remain the key. Two surgical approaches can be combined in tumors at risk for loss of vision. Postoperative visual recovery depends on the preoperative findings. Smaller tumors with small refractory errors are favorable parameters. Long-standing tumors with a globe indentation can lead to choroidal folds. So we propose early surgical intervention in symptomatic intracorneal cavernous malformation. Thank you.
Is the dual approach unique in this,
Yeah.
or has it been described before?
Not in all the series, they did only lateral, mostly lateral orbit or lid split, but they have not combined lateral orbit with lid split. Basically, you will get more space for retraction. So that was my aim. When I see pupil starts dilating, I will immediately go for second approach.
The lids, see, most of the cavernous hemangiomas are they're pretty big on the CT scan, but once you start operating, when you start manipulating them, the blood from it actually goes out. It becomes like a shrunken grape. So you can easily the size decreases intraoperatively because of the manipulation. So having two approaches, like normally, you must have done minimally invasive orbital surgery. You must have not cut the zygomatic arch in any of the case. So MIOS is a good technique. So I really find that having a vertical lid split, that is usually for a superior orbit tumor, and when you can actually have a superolateral entry to the fornix, it is as good. So maybe having a vertical lid split, in how many cases you required it? 2 cases, 3 cases. Okay.
In 2 cases, lateral orbit with lid split. In 1 case, lid split alone.
So basically, the problem is not the compression by the tumor when you're actually pulling it.
Yeah.
So basically, it can actually shear some vascular bundle, or it can actually cause some kind of a vascular damage rather than actually like another like neurofibromas, because they're very soft and very supple, and a lot of them actually have enophthalmos. You had how many cases?
Only one patient had enophthal. She had a very deep-seated tumor where I had to do deep lateral orbitotomy. So only one patient had enophthalmos. All others are fine.
Okay.
The length of the follow-up for the
Average follow-up is 21.8 months. Minimum follow-up 6 months.
the hypermetropia did not change in that follow-up period.
They reduced, but didn't disappear completely. Only 2 patients it disappeared completely, but all the others retained.
But it reduced.
Yeah, reduced but retained. So
Thank you.
thank you.
Okay. Thank you, Dr. Marian, PAULY.